Welcome everyone to our fourth Healthcare Data Matters webinar, where healthcare leaders and innovators join in conversation to set a new standard of patient-centered and data-driven care. I'm your host, Bruce Hall, and before we begin, I'd like to go over a few disclosures. First, funding for the Healthcare Data Matters Forum is supported in part by Medical Informatics Corp. And Intel. Presenters' opinions and viewpoints are their own, and we do not pay speakers or offer any exchange for product endorsements. You can see other disclosures on this slide. Now it's my extreme pleasure to introduce our guest today, Dr. Danielle Rios. Dr. Rios is an associate professor of pediatrics in the Division of Neonatology at the University of Iowa. She completed her residency and neonatology fellowship at Baylor College of Medicine and Texas Children's Hospital, and a fellowship in targeted neonatal echocardiography, or TnECHO, at the University of Toronto and Hospital for Sick Children. Her areas of academic focus are the improvement of outcomes in extremely low birth weight infants through predictive analytics and neonatal hemodynamics. Dr. Rios will be discussing her team's use of TnECHO to improve care through diagnostic precision. How are you doing today, Dr. Rios?
Hi, Bruce. Thank you so much for having me.
And it's so great to have you with us. Let's talk a little bit about some of the logistics of our presentation. Our format today is, first, I'll ask you some questions to give you the chance to present your study to our audience members and your practice. And during our talk, audience members can type any questions they may have in the Q&A tab as shown on this slide. We'll address as many questions as we have time for at the end of our session. Sound good?
Sounds good.
Okay, great. Once again, thanks for being with us, and let's dive right in. First, can you tell us about the University of Iowa's Neonatal Hemodynamics program?
Sure. Once again, thank you for allowing me to talk about this today. So let's start off with a little information about the University of Iowa and its program. It was the first neonatal hemodynamics program of its kind in the United States, and it was patterned after the pioneering work done at Toronto's Hospital for Sick Children and other medical centers in Canada. The program was started by Patrick McNamara, a recognized leader in neonatal hemodynamics, after he moved to Iowa. What we're looking at on this slide is an already outdated picture of the hemodynamics team workspace because we have had to add another EchoPack workstation since this photo was taken to support the number of learners involved in our research projects. The program now consists of 4 faculty members who are pictured along the bottom right, me being one of them, who perform more than 1,200 hemodynamics consultations per year. We also offer neonatal hemodynamics fellowship training for interested individuals who have completed a fellowship in neonatology. Traditionally, this is a 1-year intensive training program, but we also welcome shorter-term learners. Well, at least we have, and we will again once this pandemic is over.
Well, it certainly seems like your specialty is expanding, as indicated by your outdated picture. Can you tell us a little bit more about the specialty of neonatal hemodynamics, which I understand combines your specialty of TnECHO with physiologic and other data? It's widely adopted in other countries like Canada, we know, but what is so unique about the specialty? Why is it important, and how is it evolving?
Sure. So why is it important, you ask? Well, in our current state of practice, neonatologists are forced to function utilizing a symptom-based approach. Let me explain it a little more. When we are faced with a critically ill patient that is deteriorating at the bedside, we evaluate the symptoms, including poor perfusion, blood pressure values, oxygenation status, metabolic status, etc., which are measurements that essentially can tell you that something is wrong, but they can't tell you what it is that is wrong. We're somewhat trained to respond to these symptoms with the listed interventions. So for example, let's take hypotension. It's not uncommon for clinicians to first give a fluid bolus, then start some medication such as dopamine. If that's not working, hey, let's crank it all the way up or maybe add something else. So dobutamine, epinephrine, maybe some hydrocortisone, depending on their institutional protocols. The main problem with this approach is that there's a lack of precision. Without understanding the actual physiology, it's really difficult to determine whether the hemodynamic instability is the result of a PDA. Is it pulmonary hypertension? Is it heart dysfunction? Is it something else? And we also don't know what the effect on organ perfusion is. Any of these physiologies could give the nonspecific symptoms listed on this slide, though we may not necessarily think of PDA, for example, when we have an oxygenation problem. Having real-time physiologic data provides the ability for us to deliver more focused and targeted cardiovascular care to this population.
So you have this lack of precision, you have these symptoms. Can you tell us an example of maybe a case where you use data to support your clinical intuition?
Sure, Bruce. Let's talk about a term male who was born via emergency C-section at an outside institution. He had a difficult delivery and required extensive resuscitation, including chest compressions. He had a significant metabolic acidosis on his initial gas, as shown here. And for all of these reasons, he was transferred to us, where he was diagnosed with moderate hypoxic ischemic encephalopathy, or HIE, and he was started on whole body cooling. I came in to take over his care in the morning after about 8 hours or so of his after his admission. Looking at the medical record, we noticed an appropriate response to the hypothermia, including his lower heart rate and his lower temperature. At the time that I saw him, he actually looked clinically well. He was saturating in the 90s on 21% FiO2 with normal blood pressures. However, it's our routine protocol in the NICU here at University of Iowa to obtain a hemodynamics consultation. And this is what we saw on TnECHO. The top left image is his apical four-chamber view, with the chambers labeled for the right atrium and left atrium, RA and LA, and right and left ventricles, RV and LV. Note the difference between his severely dysfunctional left ventricle as compared to the middle top picture of a normal moving apical four-chamber view. With this severe dysfunction, he also had poor cardiac output, which would be expected. And this is shown in the bottom left image. That's his left ventricular output compared to the middle bottom picture of a normal size Doppler. The right top image is the RV3 chamber view, showing the inflow and the outflow of the RV in this image. The label PA is the main pulmonary artery before it bifurcates into the right and left PA, so the outflow tract of the RV. So we can see that he actually has RV dysfunction as well. However, it doesn't look as poorly functional as the left ventricle in the other picture. The bottom right image shows the peristernal long view of the RV, the LV, and the LA. It also happens to show clot formation at the origination of the left coronary artery. So that is just to the right of the aortic valve, which is kind of in the middle of that picture. And the clot is what's depicted with that yellow arrow. This patient was urgently taken to the cath lab for TPA installation to the left coronary artery for restoration of blood flow. Can go to the next slide, please. So a case like this can be shocking since the patient appeared clinically well, even in the setting of severe heart dysfunction, so severe left ventricular dysfunction and moderate right dysfunction. Thankfully, since routine clinical monitoring did not identify a problem, our routine TnECHO protocol did. I think it's obvious how the extra data from the TnECHO helped since we were able to get our cardiologists involved early for an intervention. But, could continuous monitoring of other sorts of helped? Well, let's look back at our documented vital signs, specifically saturations and FiO2 requirement as shown on this slide along the top from our EMR. Beneath them are the continuous vital sign data that we also simultaneously collect without the need for any intervention from our clinical staff or our bedside nursing. It's just automatically collected. Perhaps the saturations shown in blue were not quite as stable as the data that was filed hourly to the EMR made it seem. So this could potentially have prompted a hemodynamics consultation as well. Although even with continuous monitoring, this patient looked clinically well in the last several hours prior to our routine TnECHO. So without a doubt, this patient would have deteriorated quickly without an urgent intervention resulting from the findings of our TnECHO.
So what a wonderful and positive impact you had based on the TnECHO study that you did. Can you broaden that for us a little bit and talk more about overall impact? What kind of statistics or outcomes has the specialty demonstrated?
Sure, Bruce, of course. So over the last 15 years, hemodynamic specialists and researchers have published over 1,000 manuscripts, which have cultivated enhanced understanding of disease mechanisms, impact of interventions, and outcomes as they apply to the newborn with hemodynamic instability. Many of these publications have led to sentinel changes in practice, which have then led to major enhancements in patient care, which was the ultimate reason this field was born in the first place. A couple important examples of the mechanistic impact include findings of early left or right ventricular dysfunction and its association with severity of disease in congenital diaphragmatic hernia and HIE respectively. Next slide, please. A few examples of the clinical impact of TnECHO are listed here, including decreasing recovery time, incidence of PLCS, which is post-ligation cardiac syndrome, and length of exposure to medications. A couple studies have also evaluated TnECHO services in general, and one showed in nearly half of cases, the hemodynamics consultation resulted in a change in clinical management, and in nearly a quarter of cases, they avoided a planned and likely unnecessary intervention. The other showed in acute hemodynamic instability, 80% of the time, the consultation provided novel insight into the pathophysiology, meaning what the neonatologist thought was going on was actually not the case when you looked at the physiology. I think this highlights the poor accuracy of the symptom-based approach and the need for further information and further data in these cases. In fact, in cases of hypoxic respiratory failure that have been transferred to the University of Iowa NICU for ECMO, so ECMO referrals, a majority have avoided cannulation with prompt serial physiologic assessments and alterations of medication therapy to treat the actual current disease pathophysiology.
Boy, again, some wonderful impact the discipline seems to be having out there on the floor. Let's turn our attention to the research side just for a second. Now that you have all this data, are you and your team working on anything in particular?
Yes, so we actually have a lot of research projects that are ongoing and or in the works. And like I mentioned before, some of our fellows and medical students, we have also working on some projects. But the one that I'm going to talk to you about today a little bit is what I'm currently focused on. And this has to do with taking all of the physiologic data that we have access to in order to kind of put it all together and create algorithms that can distinguish patients that are at increased risk of suffering an untoward outcome from those that are at minimal risk of suffering the same outcome. In this case, as you can see over on the right, our focus is on the brain, kidney, and intestinal injuries that these premature infants regularly suffer, unfortunately. So ultimately, with this particular research project, what we hope and expect to have is a real-time physiologic risk index that can be monitored kind of like an extra vital sign at the bedside so that the clinicians can respond to it in real time and see it increase or decrease based on that patient's current status for risk of having the untoward outcome.
Really very interesting on the research side there. Dr. Rios, is evidenced by your outdated picture, it seems critically important to recruit more specialists for this field and foster collaboration. I understand you're involved with some efforts to help advance the field?
Yeah, so let me briefly mention 3 different ways. So recently, the Neonatal Hemodynamics TnECHO Specialty Interest Group, or SIG, was established at the American Society of Echocardiography, or ACE. So those ACE members with an interest in TnECHO are encouraged to join, and actually anyone interested or working with TnECHO in general should also consider joining both ACE and the SIG. For general information about the specialty, including current sites with hemodynamics consultation services, individuals can visit the Neonatal Hemodynamics website as it's listed on the slide, www.neonatalhemodynamics.com. Additionally, we have the Pan American Hemodynamics Collaborative, which works to expand the specialty. It was originally started in Canada and now involves a lot more of the US and others in other countries as well. And focus is making protocols, sharing experiences, and those kinds of things to help others out.
So once again, that website, neonatalhemodynamics.com. Very
Yes.
straightforward. That's the name of your specialty, right? Good. Could we drill a little bit more into collaboration? We have a complex population and a growing specialty. Do you hope to work with other centers to accelerate some of your research work?
Yeah, so one of the challenges with progressing specialties in research in general is that oftentimes one single institution may not have the number of patients required to complete timely research. So having multiple sites and established protocols, not only just research protocols, but also the protocols for obtaining TnECHO images, et cetera, this can assist with us being able to share that data, which then leads to increased productivity amongst all of the different sites. So currently participating sites are listed on the website. As you can see here, the University of Iowa is on there and Boston Children's, and then also, of course, there's going to be the Canadian sites as well. So we hope to continue expanding this to other institutions. So we'll continue updating the website as other institutions join.
Well, some impressive work there. Thank you so much for your presentation, Dr. Rios, and especially impressive that now that we're thrust into this new world of virtual learning, that you and your colleagues have taken on that venture in the midst of trying to administer complex neonatal hemodynamics care. At this point, we've had a number of questions that have come in from our audience members. I'm going to now turn it over to Raj Patel, who is MIC's Director of Research, to help moderate and facilitate those questions. Raj, are you there?
Hi, Bruce. Can you hear me?
I can. Take it away.
Great. Yeah, so we have a few questions coming through the Q&A. Feel free to submit them, while I'm asking these as well. The first question that came through, can you talk a little bit more about the other physiologic data elements that you use to further inform your decisions?
Sure. So, we talked a little bit about heart rate and SpO2 and all of those things. But in addition, what we like to do is continuous monitoring on any type of physiologic data that we can. So some of the things that we use for research and clinical purposes as well would be NIRS, near infrared spectroscopy, non-invasive cardiac output monitoring. So we, here at least at the University of Iowa, we have the ability to collect that data continuously and store it for the long periods of time for us to be able to go back and access it again. We're also working on things like amplitude integrated EEG. So, if you can see the actual changes in the EEG and connect them, timestamp them, if you will, with the other physiologic data, that'll give you so much more information. So there's just a myriad of options for physiologic data that we could use to help inform our decisions.
Okay. Next question. Can you talk a little bit more about the training and who I can contact about joining a program or entering one?
Sure. So as I kind of briefly mentioned, University of Iowa does have a training program. However, we're not the only program. There's lots of programs across the country and North America in general. So one way that I would suggest getting more information is to go to the www.neonatalhemodynamics.com. And there's actually training program sites, and you can actually look at the different trainees there. We also list them on the website that are currently involved in the programs, where they can get more information. And then it also has the contact information of the different programs as well. So that people can just get more information in that sense as well.
All right. And more questions are coming through. Is hemodynamics the same as, and forgive me if I pronounce this wrong, POCUS, P-O-C-U-S? The question, the asker has done a course recently so they can perform hemodynamic evaluations.
So I think specifically we have to talk about neonatal hemodynamics. So yes, neonatal hemodynamics is different from POCUS. POCUS does have a cardiology or an echocardiography portion. However, POCUS is something that is more often used in older patients, in PICU, in the EC, in adults, etc., where they can use ultrasound and just POCUS is point of care ultrasound, for those that don't know that abbreviation.
Yeah.
So they can use ultrasound to make quick decisions. The difference between POCUS and neonatal hemodynamics is that, number one, oftentimes these are newborn babies who have never had a cardiology evaluation, and they haven't lived long enough to know that they don't have some type of critical congenital heart disease. So we do a comprehensive assessment, a comprehensive TnECHO, to also make sure that their hearts are structurally normal. So neonatal hemodynamics is, a specialty in evaluating physiology in patients with structurally normal hearts. So that's one aspect that we need to rule out. So that's why we work really closely with our cardiologists to ensure that we're getting the images necessary to affect change and to rule that out. The other thing is that physiology is dynamic, right? So this allows us to have serial assessments. And if we were to look at just the one picture of heart function, for instance, now in the case that I said, of course, that heart function was obviously bad. However, if you look, the heart may be functioning normally, and you could still have some other physiology that is severely affecting this patient. So a quick look at one image is not going to provide the same amount of data necessary for us to be able to work with these critically ill patients.
Very cool. So the specialty is neonatal hemodynamics and getting videos instead of pictures.
Well, getting comprehensive evaluations of all the different shunts in the heart, all the different parts of the heart. So not just one picture. Yes.
Got it. So seeing as this new specialty is, coming up with different data models and for a particular patient population, how can the healthcare community best support expand this new specialty?
Yeah, so I think that people just with an interest in the specialty should join in on, we have webinars that are quarterly from the Pan American Hemodynamics Collaborative. We actually were planning a conference that was oftentimes held in Canada, or since its inception has been held in Canada. And again, with this whole Pan American Hemodynamics Collaborative, we were going to alternate from the US to Canada back and forth, but things like that. So the next time it will be held here at University of Iowa, hopefully in 2021, because it could not be held in 2020. So coming to those kind of conferences and learning just more about what neonatal hemodynamics really stands for, what it means, what TnECHO really means, learning more about the protocols, coming and visiting when this pandemic is over, and getting an idea of what we do here at University of Iowa and other institutions that have hemodynamics consultation services. So just getting more information and asking more questions, I think, is the way for it to be supported.
For sure. And seeing you over Zoom is great, but having the in-room
Yes.
exchange of knowledge is unparalleled.
Yes, there was an echo simulator, if you were looking at that picture, that a lot of even the cardiology fellows sometimes just love to come and play with and, get the different views and looking at things. And that's one of the highlights of our conferences is an echo workshop, a TnECHO workshop. So we do have live patients, children, who will allow you to scan them, but then also the simulators that the attendees tend to really enjoy.
That sounds really educational. A couple more questions coming through. How are you time syncing and harmonizing echo data with the rest of the hemodynamics?
Yeah, so that is one of the most difficult portions of this. And so what we do is we timestamp the beginning of the echo. And we are able to look at the actual echo images in our echo pack system, essentially, to see the times if needed, if there was actually, we wanted to exactly see the time on what we have is sick bay, that, you know, we were looking at this one image for whatever reason that would be, we could still look at that because everything else is time stamped. But unfortunately, we have to have the technology and all the different modalities that we're using, and our echo is not quite able to give us that real-time timestamp at the moment.
Yeah, data integration and ongoing,
Yes.
ongoing work, ongoing project.
Yes.
A couple more questions. As you aim to build new risk indicators available at the bedside, can you share your insights on how much of an issue alarm fatigue might be? Because the additional indicators would add to existing alarms on standard patient monitors. What could be a better way to handle different kinds of alarms?
Yeah, so so there's actually a lot of work on alarm fatigue, and that is something that I think is very, very important. Maybe I'm misunderstanding the question, but in discussing kind of what I was talking about with the research, it actually wouldn't necessarily be kind of extra alarms, but it would actually be an ongoing kind of signal where, if you can imagine a heart rate tracing that would kind of just go up and down, and you know, after a certain point you would see it kind of staying at the baseline, and then once you see it going up, it's just kind of oh, hey, this is going up. So it wouldn't necessarily alarm you for you know, any bump or any different change from baseline. It would be one that's actually considered significant. So 3 times the risk. It wouldn't be 1.2 times the risk. So I think that we would integrate ensuring that when you are notified, it is an actual risk increase.
Got it. So there'd be a derived trend that would,
Correct.
got it. Okay. And then a question that's maybe near and dear to my heart. What does your research team look like? What kind of expertise do you need to do this kind of work?
Yeah, so our research team is actually very diverse. So of course we have the 4 hemodynamics faculty that are involved in our research projects. And again, this is just at the University of Iowa, and there's lots of hemodynamics researchers all across the world. But just here, we have us 4, and then our hemodynamics fellow is also involved in our research projects. Now that fellow learns how to obtain all of the images plus measure the images. So ideally that would be kind of the training. So going and doing a hemodynamics fellowship, and then being able to kind of take this on your own, and being able to actually obtain and measure and interpret these images, which is an important part of the clinical side of it. But in addition to that, we also have residents that are interested, or other neonatology fellows that are interested, who may not be able to learn how to obtain all of those images. We allow them to kind of do, to the extent of their abilities, what they're able. So some of our current neonatology fellows have learned to measure the echoes, so they can actually go measure their own research echoes and be able to be intimately involved in that research project. Others, like the residents or the medical students that we have involved, aren't able to do that. So, you know, we help them out with those measurements and just kind of try to get them to understand the physiology. So it varies based on level of training, what their necessary level of involvement and understanding of this work is. I hope that answered the question.
Yeah, I mean, and so it sounds like along with the clinical training that you've got, there's some research training going on too, to bring people up to those levels where they can affect clinical care. You know,
Yeah.
Yeah, that's
Yeah,
great.
for instance, when I was doing my hemodynamics fellowship, you know, I took a 2-month block where I was able to actually do a research project as well. And so I spent part of my time doing the clinical part, and then some of the other time doing the research part of it, and remeasuring things, etc. But not everybody can really do that. So we try to adjust our expectations for others' abilities.
That makes sense. All right, we've got a couple minutes left. I want to be cognizant of time. So Bruce, passing it back on to you.
Thank you so much, Raj. And Dr. Rios, once again, thank you so much for all this great information, for sharing your clinical experience, everything with TnECHO and Neonatal Hemodynamics. I think just some wonderful information for our audience. To the folks out there, we will make Dr. Rios' slide deck and a replay of this webinar and an audio podcast version available on healthcaredatamatters.com. While you're there, you can also check out the previous webinars we've done and join the conversation on our associated media channels. You'll be receiving a short survey after today's session. If you could fill that out, we'd really appreciate it, see how we can do better. We'll also be in touch with information at our next Healthcare Data Matters webinar. We have a great lineup in store for 2021, so we hope to see you then. In the meantime, we want to wish everyone a wonderful and safe holiday season and a very happy new year. And we'd like to thank you once again for joining us today. Here at Healthcare Data Matters, we are grateful to have the opportunity to advance a new standard of patient-centered and data-driven care. Take care and stay safe, everyone.
Thank you, Bruce.